Okay. All right, we're going to get started. Good evening, everyone, and welcome to the 21st Annual Global Health Symposium entitled Establishing Trust for Emergency Preparedness, the Role of Universities and Alliances. Tonight's event is presented by UW-Madison's Global Health Institute, the Office of Global Health in the School of Medicine and Public Health, and the College of Agricultural and Life Sciences. My name is Kaylin Ostrowski, and I serve as the Associate Director of Strategic Partnerships and Development at GHI. And I have the good fortune of kicking off tonight's event in celebration of GHI's 15th anniversary at UW-Madison. As we begin, let's please take a moment to ground ourselves and remember that we are on the ancestral homelands of the Ho-Chunk Nation, who called this place Dejope since time immemorial. The UW-Madison Our Shared Future marker on Bascom Hill tells us how this sovereign nation faced decades of forced removal and ethnic cleansing. We celebrate and recognize today's vibrant culture and the ongoing contributions of the Ho-Chunk Nation and all of Wisconsin's 12 Native nations. We are honored that the Indigenous elders, scholars, and communities are willing to share their knowledge that leads all of us toward a more equitable and sustainable future. As UW-Madison's Global Health Hub for the past 15 plus years, the Global Health Institute proudly serves as a catalyst, incubating innovative research, education, and outreach efforts while supporting successful organizations and initiatives which originated within or are hosted by GHI, to contribute to a shared vision of improving health and well-being for communities in Wisconsin and around the world. GHI's network brings together partners across academia, government, industry, and NGOs to build alliances that advance global health solutions. Through these collaborations, UW-Madison researchers gain valuable opportunities to work in real-world settings and exchange knowledge with partners across the globe. These partnerships also create meaningful learning opportunities for students. GHI-affiliated international internships and scholarships provide immersive, hands-on experiences that strengthen cultural understanding, build professional skills, and deepen students' commitment to global service. You can see the impact of these programs through GHI's new video series, featuring student and faculty perspectives. The first new series is entitled Voices of GHI, and it shares insights from leaders, and GHI Journeys follows students in the field. You can find these stories on GHI's YouTube channel and our social media and on our weekly newsletter. Today, we continue to foster community engagement through initiatives such as the monthly Global Health Tuesday webinar series and our annual symposium, which brings together hundreds of community members, researchers, and practitioners from UW-Madison and around the world each year. These gatherings highlight the complexity of global health challenges and the many kinds of expertise required to address them. Since its inception, GHI has distributed over $2 million in seed funding to support action-oriented research. Many of these pilot projects have gone on to large-scale initiatives backed by extramural funding. And this evening, we are very excited to announce that thanks to the generosity of Dr. Henry Anderson, who is somewhere here, thank you, Dr. Anderson, we are excited to be launching a new seed grant opportunity titled the GHI Rise Thrive Grant Accelerator Program. This program will support faculty-led projects aligned with Rise Thrive priority areas with a focus on work that demonstrates clear public and global health impact. For the next 2 years, 2 seed grants of up to $15,000 each will be awarded to both new and established investigators to help launch innovative research and build long-term collaborations that drive meaningful outcomes. While applications are not open yet, additional details, including the timeline and application process, will be available on our website and our newsletter very soon. And GHI's impact is not possible without the leadership of our advisory committee, our board of visitors, and the many community partners and global partners. That's why I'm especially grateful to be here alongside my colleagues and friends, Drs. James Conway and Jennifer Kushner. Their guidance has been invaluable, and during a time of uncertainty, their support has meant a great deal to me and the GHI team. So thank you, Jim and Jennifer. We have a wonderful program for you this evening, and I'm pleased to now transition to our fireside chat and introduce our moderator, Dr. James Conway. Dr. Conway is a professor of pediatrics at the University of Wisconsin-Madison School of Medicine and Public Health, where he serves as Pediatric Infectious Disease Fellowship Program Director and the Director of the Office of Global Health within the School of Medicine. He also serves as the Medical Director for UW Health Immunization Programs. He is responsible for coordinating global health educational programs involving health professional students at UW-Madison and oversees the international programs in the UW School of Medicine and Public Health. Dr. Conway has spent much of his career working to improve immunization systems and address vaccine hesitancy in the U.S. and abroad. He is a fellow of the American Academy of Pediatrics, a member of the Pediatric Infectious Disease Society Vaccine Advocacy Committee, and has served on the American Board of Pediatrics. In his most recent project, he serves as a technical and global sustainability advisor for a collaboration between the American Academy of Pediatrics and the Centers of Disease Control, working to simultaneously strengthen pediatric professional societies and immunization programs in over a dozen high-priority countries in Africa and Asia. Please join me in welcoming Dr. Conway.
Thanks so much, Kaylin. It's a great pleasure to be here, and I can't thank all of you enough for being here, those of you here in person as well as those of you online. We've got people from all over the world joining us, and I think this is truly a global conference and a global meeting that we're all a part of here today. In this increasingly interconnected world, global health academic alliances are essential, especially during community health emergencies. Many of you may know about our recent measles exposure here on campus, and living through the process of coordinating that was a small glimpse into what these kinds of activities really are all about. Academic alliances advance research, improve health outcomes, and strengthen the resilience of systems both in Wisconsin and around the world, while also building trusted communication networks grounded in clear, evidence-based, science-based information. This evening, we're going to hear from a diverse panel of researchers and experts who are going to discuss their roles and experiences and how they've contributed to critical examples of establishing trust for emergency preparedness. As you're going to hear tonight, convening expertise across human, animal, and environmental health helps us better understand why local to global networks and alliances are essential in building and establishing trust during emergencies. I think we all know that trust is one of the most important things in public health and one of the things that's been sorely lacking over these last few years. Hopefully this will give you a little bit of a glimpse into where a university, especially a leading global university, may have a role in helping improve those problems of communications and trust that we all face every day. Following our esteemed panels, we're going to be honored to welcome my friend and colleague, Dr. Ryan Westergaard, as our keynote, who's going to discuss his experiences with public health emergencies, both here in Wisconsin and abroad, as well as his approach to building trust as a public health leader. A couple quick housekeeping tips they've got here for me. Following the fireside chat and the keynote, there's going to be time for Q&A. So we'd ask people to sit tight during the presentations and the discussion and hold those questions till the end. During that time, we'll come around with microphones so you can have your part of your 15 minutes of fame. And if you're watching online, please put those comments and questions into the chat. I've been promised by John that we have some kind of magical technology that will allow those questions to then pop up on this crazy screen here for our panelists. This event is being recorded, so for those of you who have colleagues who you're going to say missed out on something really great, they will have another opportunity to take a look and understand this. I'm told that this will be posted on the Global Health Institute website tomorrow if all goes well. So, without further ado, I'm going to start introducing our panelists and have people come join me on stage so that I'm not lonely up here anymore. First off, I'm going to introduce Dr. Nan Lee, who's an associate professor in the Department of Life Sciences Communication at UW-Madison. You can come on up. Gives them something else to look at. She's affiliated with the Robert F. and Jean Holtz Center for Science and Technology Studies, the McPherson Eye Research Institute, and the Office of Sustainability, as well as the Wisconsin Institute of Discovery, where we're sitting right now. Dr. Lee's research examines how visual communication shapes the way people understand and engage with science. Her recent work focuses on how scientific images and data visualizations are translated by the media, how widely circulated visuals such as science photos and AI-generated illustrations shape perceptions of credibility in the issues they depict, and how science art fosters emotional engagement and self-reflection in the context of environmental risk and justice. So join me in welcoming Dr. Nan Lee. Our next contestant is my friend and colleague, Dr. Keith Poulsen. In addition to being an incredible skier, Keith is the director of the Wisconsin Veterinary Diagnostic Laboratory and a clinical assistant professor in the Medical Sciences Department at the UW School of Veterinary Medicine. Keith is actively involved in the Wisconsin Veterinary Medical Association, the American College of Veterinary Internal Medicine, the National Animal Health Laboratory Network, and the American Association of Veterinary Laboratory Diagnosticians. His interests focus on cattle health, zoonotic infectious diseases, and global health, but he is truly a polyglot and can talk about almost anything related to infectious diseases in animals. So welcome, Keith, to the stage. Next up, I have the pleasure of introducing Crystal Potts, who I've just most recently met. She's the Assistant Vice Chancellor for University Relations and Senior Director of State Relations and Statewide Outreach for the University of Wisconsin-Madison. In her role, she serves as the point of contact for state government relations, including the governor's office, the state legislature, and state agencies. She also assists in the creation and implementation of a statewide advocacy effort on behalf of the university. Crystal previously served as the Chief of Staff for Wisconsin State Senator Howard Markline, Republican from Spring Green, where she supported the legislature's Budget Writing Joint Finance Committee, also known as the all-powerful committee of the state legislature, as the Senate staff lead on tax and local government issues. So welcome, Crystal. And then last but not least, I'd like you to welcome Dr. Craig Hedberg. Craig made the drive over from Minneapolis for us today. He's an epidemiologist and professor in the Division of Environmental Health Sciences at the University of Minnesota School of Public Health. He serves as the principal investigator of the Upper Midwest Center for Public Health Preparedness and Response and co-director for the Minnesota Integrated Food Safety Center of Excellence. His most important contributions have been to advance methods for collaboration between public health and regulatory agencies, academic researchers, and industry to improve foodborne illness surveillance and outbreak investigation. He promotes these same approaches to enhance public health preparedness and response, addressing key barriers to implementing evidence-based strategies and interventions. So welcome, Craig. And with that, I'm going to grab a seat and let these smart people give you their perspectives on this topic. I don't know who's first.
I see my slides next.
Oh, do you want me to flip it?
Maybe, yeah. I have some animation.
Okay, perfect.
Oh, an animation.
Yeah. So never underestimate the power of a veterinarian with artificial intelligence. So most of what I thought I was going to talk about, that all changed on Monday, but I typically talk about how do we manage infectious disease outbreaks. And when we really think about it as a three-legged stool, we're all up here, maybe the science is the easy part, right? Where we then spend more time talking about the economic and political implications, whether that's all politics or local. Ben Bransel taught me that about 15 years ago. He's a Wisconsin politician. And the reason why I spend so much time in the Capitol with Crystal. And then with the economics, whether it's a dairy, I focus on animal protein, so whether that's dairy or poultry. But it all changed, and I'll get to why there's a cow with vacas there in a second. It all changed on Monday. I was sitting in Farm Bureau, and the biggest concern that we have, and I thought instead of talking about the links to infectious disease with zoonotic concerns in a global health setting, let's talk about what's happening immediately right now, right? What are we talking about? And we're talking about fertilizer, costs of diesel, and political trade implications and policy, right? So why do we care about fertilizer, potash, potassium, nitrogen? We make most of it in the United States, Canada, or Brazil. It's because the Strait of Hormuz is closed, right? So that makes our global supply drop precipitously. And what does that mean right now? It means our increased costs of production are up, or our production costs are elevated. And just to kind of think about this to set the stage for the things that I'm working on every day, even from my drive from campus to Lodi, where I live, is that we're going to be out planting, right? So right now in Farm Bureau, all of our members of the Ag Coalition are thinking about how are we going to find the fertilizer and what are we going to plant, right? Is it going to be beans or corn or alfalfa? What's going to happen? And much of what we plant is dependent on how much manure is in the lagoon, so we can only put the nutrients back on the soil as what we take out. And what is that cost going to be over time? So we're thinking about how much is it going to cost to actually plant these fields. And then we're going to have all this time, and there's going to be a lot of time, and there's a lot of variables in here. But what about then coming into harvest? What's fuel costs going to do, and what are the yields going to be? Because it's not a free market, right? For ag, it's very controlled. Most of those prices are set right now, or they're set by specific programs. And then we're going to come into, here's what everyone else was really concerned about, is that eventually food costs are going to go up, right? And we're going to see, anyone remember $12 a dozen eggs, right? So when the consumer sees it on the shelf, it's going to be an issue. And what we're really concerned about is that, the farmers are making all this money. But hopefully what we'll see, and what I'll show you here, I just have a few minutes, is that the costs and the inputs, the farmers are actually going to feel it first. And they're also going to be the longest. They're going to be the last to see reprieve. So what are the wild cards in there? That's what I'm really interested in on the animal side, is that we have infectious diseases. Right now we're measuring 4 imminent threats to U.S. animal agriculture. We have highly pathogenic avian influenza in multiple species. We have African swine fever that's on the island of Hispaniola and probably Cuba. And then we have New World screwworm, that's a great story, coming up through Mexico, right? And how we change that and what are we going to do about it? And then foot and mouth disease is alive and well, right? So we saw outbreaks in the EU last year. Anyone hear about El Nino, right? El Nino is coming. We could have some disastrous weather that could affect, or maybe we could have other geopolitical missteps. Now, that's a pretty vague term, but if anyone has watched the news, like in the last 18 months, that could be anything. It could be something from our friends in Europe or in Asia, or just even right here at home. So with that, we worry and are concerned about the animal agriculture economy, especially in a state like Wisconsin that has such a large dependence. Now, what does that mean for people, right? That's why we're here, is that we're in a kind of a One Health, or human health and animal health leading together. And hopefully this maybe even will set the stage for some of the questions or discussion that we have today. But remember, 66% of the protein that is consumed by the US public is from animal-based protein. And guess what animals eat? Plants. So it's really all interconnected. Nothing happens in a vacuum, right? And just thinking about that for what we just showed for animal-based protein, we think about meat, so beef, pork, and poultry. It's about 8% of our total caloric intake in the United States. What about dairy, right? So dairy is going to be 25% of the protein, 4%. But just think about everything that maybe you ate out in the refreshments, is that dairy's mixed and it's in about a quarter of our food products, right? Same thing with eggs. We all thought about eggs and maybe dyed some eggs last week. I did with the kids. Now I have a lot of egg salad, right? But liquid egg is in almost everything that you eat in small amounts. So we are going to see this affected. And when we think about this as food safety, which we do in the Food Research Institute here on campus in microbial sciences, we start to think too about food security, right? Can you get food at the price that you want, right? We're very spoiled in the United States, where we can get avocados pretty much any time of the year, right? Or star fruit, or pomegranate, right? But it's not going to be just about that. It's going to be, well, what about some of the other staple vegetables, wheat, corn, maize, beans, right? The soy latte drinkers, you're going to be affected. Okay, so when food prices rise, this is the last thing I want to talk about, it turns into a pretty nasty cycle. And a lot of that will depend and has amplified by other infectious diseases that come in. And what does that do with trade? Remember that three-legged stool? Well, here's what's going to happen this fall. It doesn't matter what happens with the current ceasefire or whatever. The Ukraine war and a lot of other geopolitical issues they're going to create issues for this planting season and probably the next, where we're going to see grocery store sticker shock more than what we've seen in the last few years. And then we're going to see media, right? Because the media is going to cover it and then it's going to make it worse. It's kind of like the first person that made the run on toilet paper at Costco. Remember from 5 years ago? And then everyone suffered, right? So after that, we will see government changes or assistance. It will change imports. It will put pressure on markets. We did that. We bought over 100 million eggs last year about this time. We spent $20 billion in beef in Argentina, but those were short-term effects, and it really destabilized our markets, as well as the people that produce food in this country. So we're going to see short-term changes and a lot of market variability, volatility. It's going to be really hard to point at one particular spot. And then that's going to increase our risk because we're bringing in food from different areas or animal proteins. So what about foreign animal diseases that really impact our rural economies? What about strain trade relationships? And what we're really concerned about too is flooding our market with cheap protein. So we're talking about protein that's a lot cheaper to make in other areas than it is in the United States. That's a real effect for large industries that support rural communities and our food safety. That really then leads to U.S. ag losing competitiveness. We've led the world since the Green Revolution. Now you can argue forward and against what that means on a large scale, but in the end, much of what we do relies upon how efficient we are at making food for our country and the rest of the world. And then there are other major market issues that could really amplify these problems. So what that really means then is, to me, is these short-term cycles just kind of churn and churn and churn. And we've seen those cycles churn faster now with as much uncertainties that we have. Human health is going to rely on food safety, food security, as well as infectious diseases, economy, and our environment. That's why we're here in the Global Health Institute. And then I'm going to leave that back to what does VACUS mean, right? My former boss, when I showed him this logo for something else, said, "Oh, you misspelled VACUS. VACUS is spelled with one C." And I think he was on a remote meeting and he was learning Spanish. He was in Mexico at the time. And I said, "No, Mark, VACUS, that's the Latin spelling." And VACUS is an idea. It's the Latin spelling for cows. It's an idea about abundant and safe protein to help our populations grow, leading to education and prosperity. So this here this is Swahili for healthy cows, healthy people, and it's from a program that we did just recently last week in Tanzania, promoting milk sanitation and breeding. So that's kind of what I had to say to kind of introduce what I do. It's pretty broad, but I see lots of different interests all over the place. So I'm going to go back. I think, am I the only one with slides?
I thought I had slides,
Oh,
Yeah.
but I don't know. Oh, there it is.
oh,
Perfect.
okay.
I'm happy to
Off
go
to you,
next.
Crystal. Now for something totally different.
Now for something completely different. But I did not realize today that I was going to learn a phrase in Swahili. So
Oh,
thank you,
okay,
Dr.
yeah.
Poulsen, for that. Hi, everyone. Thanks again for the invitation. Thank you, Dr. Conway, for moderating this conversation. I think I'm one of those, what about these things is not like the other. I'm not a healthcare professional. I'm not a health expert, not a health policy expert. I am a political person. I graduated from here with a degree in political science. So my specialty is government and outreach and engagement across communities in Wisconsin. I wanted to just include a couple of slides and then we'll get into the conversation around building trust. When I saw this theme of this year's symposium, I was really excited to be a part of this conversation. I'm looking forward to all of your questions because university relations and what we do for the campus and for the institution writ large is to build trust in these communities. And so I thought, and then when they asked me, what kind of slides do you want to put up? I usually don't like to lean on an org chart as my founding, my foundation for my comments and presentation, but I thought that this was just a nice way of showing this audience about how broad the university relations is and how there is an infrastructure built within this institution and this campus that specifically exists to build trust within communities across the state and with the federal government as well. You'll notice just looking, if it has the word relations in it, it probably belongs to our university relations family. And I'm fortunate enough, privileged enough, blessed enough to lead our state relations and statewide outreach team. As Dr. Conway mentioned, a lot of that is state government, I would say day to day. And literally the reason I was checking my phone is because we have a bill that the governor signed today. So I was monitoring that. But 90% of the work day to day really is engaging with state government. I work with Dr. Poulsen a lot in terms of opening up those lines of communication. He has great relationships within DATCAP, which is our Department of Agriculture, and then also our industry partners as well. So I really need to compliment my friend Dr. Poulsen on his relationships, but really, managing those relationships on behalf of the entire institution, because as you can imagine, depending on what part of campus you're working with, those relationships look very different. And so I'm going to talk a little bit about this in broader buckets, really with the themes of resource, the fact that the institution, the campus is a resource to the people of this state and there's no one else like us in the state. I'm going to provide an example of when in times of emergency preparedness, we were a part of those efforts on behalf of the governor's office, Department of Health Services. I know Dr. Westergaard probably has better stories than I do. I'm going to keep it pretty broad, so don't worry. Building that trust within communities, and then sometimes how this organization, is challenged in the way that it is structured and how big we are in terms of setting priorities and, our risk aversion sometimes given sort of where we sit within the politics and within state government. I do, though, need to put in a plug. If you have any needs related to any level of government or communities, please feel free to reach out to me, reach out to any of the folks on this slide. We're really here to help you. And sometimes it's really just sharing the work that you're doing, because sometimes, you do it day to day, but then having a fresh set of eyes looking at it and saying, hey, have you thought about engaging with this new association or this new group that might be helpful to your efforts? I just want to put in a plug. Please feel free to reach out anytime. We do get into relational work for a reason. We are largely extroverts, so we love to chat and we love coffee. We're very over-caffeinated most days. A little bit, again, of what we do. I talked a little bit about it, but at least for the state perspective, this looks very similar at the federal level, but then also in our community relations with city and county government. A lot of it is advocacy and it is outreach. So it is lobbying, right? All 132 of our closest friends in the state legislature, governor's office, state agencies as well. Sometimes it's specific pieces of legislation or requests or proposals that we're working on within the legislature. Sometimes it's these longstanding partnerships that perhaps the School of Medicine and Public Health has had with the Department of Health Services. I know Dr. Westergaard also has a joint appointment as well. Those types of examples, longstanding relationships, new ideas, campus priorities, we do it all. The outreach piece I think is really important too, because we are not only asking for things, requesting things, advancing campus priorities, but then again, going back to that theme of trust, building that trust within people that operate in like 2 or 4 year cycles, very challenging, but it can be done. And then I'll talk a little bit about that as well. And then also representing the campus to statewide associations as well. So Dr. Poulsen is part of the Agriculture Coalition within the state. And I'm really happy that he's there because he brings a lot of expert advice. And that's, again, when the university serves as a resource to our industry partners, because they go and they ask Dr. Poulsen a bunch of questions. And they're very thankful that he is here on the campus. And so just kind of going through some of the themes that I had talked about, right? This idea of the institution, the university being a resource for communities, for the state, for state government, other levels of government communities, building trust within those communities, and sometimes how the organization can be challenging. First of all, I think I mentioned this previously, there's no one else like us in the state. And a lot of times that means we're the 800-pound gorilla in the room, but we are a flagship land grant institution in a state with like a moderate population of people, right? Like, I think under other circumstances, you wouldn't have an institution of this size, of this, I guess, productivity in terms of like, if you think about we're top 5 in the country, right, in the herd rankings for research. Like, should that really happen in a state with this kind of, right, upper Midwest, moderate population, as I mentioned? And so we're very special in that way. And I think if you look at the breadth of programming, professional programs, School of Medicine and Public Health, the fact that medicine and public health is together, that's really unique and special. Pharmacy, law, vet med, all of those things. There's, I think, only 6 institutions of higher education across the country that have that type of breadth. And it's here in Wisconsin, it's here in Madison. And so what a wonderful resource for the state. I think, it's not just Madison, that is affected by this. We have a 72 county strategy and, made better by the addition of Division of Extension, which I'm sure folks in this room work with as well. They have a presence in all 72 counties. Wisconsin Public Media. I mean, like, the breadth of what we've got on this campus is incredible. And so we need to be thinking about and formulating an advocacy strategy that involves all of those parts of us, because all of it is very special, especially together. State Lab of Hygiene does a lot of the testing around the state, partners with state government, DHS, DNR, that type of testing. There was recently a bill that was signed, I think just yesterday, providing additional resources for PFAS testing across the state, increased PFAS testing. VDL, right, the testing that you all do. And so, we're such a resource for the state. And so in order to sort of not forget that is a thing, and I think people sometimes often forget that because we've served as that resource for so long. I think the other thing too, when we think about emergency preparedness, we're part of, emergency operations at the state level. We work with our partners in state government and the Department of Administration, in DHS, in the governor's office. Like, we are always part of state government. We're very also uniquely positioned within state government that we are an agency of state government. And so because of that, it's an inherent partner for us. I think one example that I think too, and, the fact that it was 6 years ago, I mean, my kids are grown, but they were babies during COVID. So just remembering, I'm sort of like having these flashbacks of like locking my kids in a room while trying to have like a very important meetings. But I think, again, the emergency operations participation that we have, with state government. The other thing that's really important, the fact that we served as testing sites, we served as a partner in vaccine distribution. Like, the infrastructure that exists on this campus belongs to the state of Wisconsin, and by extension, the people of Wisconsin, right? And so when things like, emergency situations happen, when those needs arise, we, meet the moment and we provide that infrastructure for state government. And I think too, in addition to the infrastructure, in addition to being a resource, I think one of the things that we continue to work on is that trust in communities. I think it's really, really challenging, especially in a time when, if you look at the polling, if you look at people and how they feel about institutions, well, I mean, Congress is also an institution, they're not doing great either. But like, the fact that it's at an all-time low, distrust in institutions and higher ed as well. And so how are we thinking about engaging in those communities in a more meaningful way to sort of help perceptions of higher education and academic institutions, declining trust in research and in science? Like, what are we doing about all of that, right? And so, university relations, only part of that solution, because we have those pre-existing relationships with people that we've built with our work within communities and within, state and federal government. But at the same time, it's the work that you're all doing, the work and the stories that you can provide to us that then we can tell to elected officials, to policymakers, to try to insulate that trust. The other thing is like communicating early and often, right? Like, I have to deliver bad news probably once a day. And it's not, I mean, I didn't go to college for that, right? But at the same time, I think communicating early and often, letting folks know with as much time as possible so they don't read about it in the paper is like the #1 rule of thumb. And so if there are issues that you know that arise that are going to become bigger issues, like making sure that, communicating early and often, making sure that those folks have enough time to sort of process the information. And half the time, folks, think about your most challenging family member. Half the time they just want to talk at you about their upset, right? And then usually you can sort of end the conversation and it's fine, right? And that's, I think, 90% of the conversations that we have. The political landscape is very unique, and sometimes they just need to sort of say what they're going to say, but at the same time, it's those sort of one-on-one, behind the scenes conversations and the work that we're doing that ultimately will move the needle when the time comes. I would also just make a couple of comments too on organization. We're a very, very large place, and oftentimes we get caught into the challenge of being everything to everyone. And I think that that's really something that, because we're a public institution, I think people have that expectation, right? Of this is a need that I have. Why isn't my public institution providing that for me? And so, again, that's where the communication is super critical, making sure that, the campus and its units are aligned on what those priorities are, what is the level of service and delivery, and managing those expectations on the front end is a lot of what university relations does as well. This is how we're, this is the level of service we're providing. This is what we can do. This is what we can't do. In a time where everything is inherently political and everything inherently has risk, and then state and federal priorities are constantly evolving, right? And so being a public institution, during that time or during this time is especially challenging. But I think core message here is that the trust and building that trust is important, communicating early and often, and making sure that you're utilizing the people that do have those relationships to, make sure that the people that need to know, are engaged with at the appropriate time. So I think that's maybe where I'll end my comments, and just excited for the questions that are going to come. So I don't know who's next.
Yeah, I can go next. Yeah, thank you so much, everyone, for having me today. And yes, I echo a lot of things that Crystal just mentioned, especially regarding the importance of communications. I am a faculty member in the Department of Life Sciences Communication at UW-Madison. So myself and many of my colleagues over the decades have been studying this idea of trust in science. So what makes societal members trust scientists, trust the science as an institution, trust the universities? And my own research has examined, for example, how Democrats and Republicans and independents, political partisans developed their trust over the decades, towards science. And what does that trend mean? What does that trend for the way how we should communicate about our work? And what I can share is, the major finding of our collective work is trust, institutional trust is different from trust in information, if that makes sense, right? So you trust, scientists, you trust universities, that's the institutional trust. That's stable, that can be shaped by many, many different factors, like your values, who you are, who you talk to, who your families are, your lived experiences, et cetera, et cetera. But your trust in specific information is more contextual. And usually it depends on really just the message level factors, for example, the design, right? So when you look at a map, when you look at the data charts that talk about COVID-19 risk or the infected cases counts, people usually rely on, for example, the layout, the colors, the message frames, whether this is something that resonates with them, whether some efficacy information is provided, meaning they know exactly what to do after seeing all of this information. So I think there's two different types of trust, and usually people tend to think, yes, if I have that institutional trust, if people love the university, love the scientists, they will believe in whatever I said. That's usually not the case. And I can share an example, from almost 10 years ago, back in 2015. I don't know if anybody remembered that the previous Pope Francis released a church document, an encyclical, talking about climate change, and he was trying to talk about this issue with his church members at the time. And as science communication researchers, we were studying, for example, how this message was received by conservative, Catholic church members at the time. What we have found is instead of accepting Pope's message at the time, most of the people that we have surveyed instead discredit Pope Francis on that issue, because they would say, you're not a scientist, you're not even qualified to talk about this issue in the first place. Why should I trust you, right? So I think, that case, even though it's almost like 10 years ago, it still echoed with me almost every day, because it reminded me that trust is not something that you can just pick up and use that as a hook for people, right? You can not just assume people will just trust me, believe in whatever I say. I think it should be the other way around. It should be, you should cultivate people's trust in the first place. Develop messages that, echo with people, that resonate with people, that really speak directly to what people want to hear. And feel like this is something they need, feel like this is something that they can use in their everyday life. And then from there, they will develop their trust. So that's my very first point, is to really differentiate institutional trust from information trust and cultivate that level of trust before you can actually leverage it. And the second point I would say is it's really, really important for university scientists, especially in the health fields and people who are working in the disease and safety areas, to really acknowledge and talk about uncertainty. It's extremely hard to talk about it, because I feel like kids spend like almost 20, 15 minutes talking about how complex the issue could be, how much uncertainty there is within the complex system. But if you don't talk about it, if you just hide it away from people, you lose that chance to build transparency with your target audiences. So it's really important to acknowledge that science has been evolving all the time, to share with people what you may not know, what you wish you had known, to establish that transparency, and later on you can take advantage of it and use that, build transparency and trust to establish yourself as an expert and further reach your audiences. And my last point really echoes with what Crystal just shared, is work with your alliances, work with your communities, work with whoever that has your existing institutional trust, that you can co-develop your messages to maximize your credibility of your messages. I think that has been, over the decades, have been again and again shown as one of the most rigorous approaches to co-developing messages that allow scientists to reach audiences that they would otherwise not really reach without help of their partners and alliances. Yeah, that's basically what I do. I'm more than happy to take questions from there as well.
Great. Well, I'll just follow that up, because when I think about trust, I think about trust as a relationship, and it has to be built on shared expectations, mutual respect, and open communications. And as I've gone about my work over the years in surveillance of foodborne diseases in Minnesota, one of the challenges was always building trust, both with the environmental health, the local health people that the state health department works with, and the citizens of the state who have to respond to all of our queries when there was an outbreak of a disease. In building our regional center for public health preparedness, the first year of our operation was to go out and listen to the voices of the community, to find out what the needs are. And listening, I think, is really the first key step to building those relationships. Because, if I try to go in as an expert and tell a community what they need, they're just going to shut down. And so as we've been the first year of our operation around the 6-state region listening, what we continued to hear was concern about schools and infectious disease and relationships between schools and public health agencies. So we've been building a project around schools and infectious disease, and a lot of it is based on measles and the rise of measles virus transmission in school settings. And so we're going forth and building that. And to Dr. Poulsen's point, what the problems we're facing right now really reflect a lack of trust at the highest levels of our government. And really trying to rebuild that is something that at every level we need to begin to work on. I'll just...
That's great. I mean, this has raised so many interesting questions, and I'm sure people have some ideas of things that they'd like to query. I guess I'm going to ask, as the moderator, I get to ask the first question, and many more if I feel like it. One of the things that I deal with in vaccine hesitancy is obviously is a trust issue. And one of the things I find interesting as I think about all of your comments around the university and the university's intersection and collaboration with government is how the public in many ways, largely from the pandemic, but even before that, had started in large areas to distrust both of those groups. And one of the things that we've struggled with is, while obviously we can't do what we need to do on an advocacy standpoint without the government's assistance, government obviously depends on universities for information, is that external view and the distrust of this idea that there is conspiratorial activities between these organizations. So how do you address the people that are of such a mindset, which is a growing mindset, that these groups are actually collaborating to convince them to do things against their best existence? Like, how do you address that kind of deep distrust? I'll start with Nan and then sort of see what other comments people have.
Yeah, I think it's definitely an ongoing issue, and a lot of it stems from social media. It stems from, all sorts of different sources of information that people use these days. So conspiracy theory exists not just for vaccines, it exists for so many different science issues and technological issues. And it's so hard to just pull people out of that mindset, right? So I feel like one of the things, a lot of researchers have been talking about, and I see a lot of practitioners have been talking about as well, is to really bring the scientists out of their own space and to really go out there, because in this attention economy, it's hard to get people's attention if you don't go out there, if you don't step out there to talk about your own work, right? To challenge those conspiracy theories. And another thing is, while you're doing that, it's probably not a good idea to repeat what people have believed. Based on our research, again, when you're trying to debunk misinformation or conspiracy theory, the number one rule of thumb is not to repeat what people have believed already. Just talk about your work, talk about your meaningful collaborations, where you get your resources, what kind of outcomes that you have developed over the times, and more importantly, show your concern, show that, what is the genuine concern that drives your work, and to really kind of going back to some earliest points, to show who you are, to show that you care, to give your audiences that human side of the science, I think will definitely help, just counter a lot of the misinformation and conspiracy theories that people see. Yeah.
Great. I'm glad you raised social media, because that was going to be sort of where I would think about this. So Crystal, I mean, from your standpoint, as the university has obviously a platform for these kinds of messaging, how does the university use social media, monitor social media, manage social media in a way that's productive and builds trust?
Yeah, that's a really great question. And I sort of want to answer a little bit of the previous question related to when we are having challenging conversations with, any one of our stakeholders. I think, if folks have read The Anxious Generation, social media, it made me want to put my phone away for weeks after that, right? And I've got little kids at home, so it scared the crap on me. But so I think social media is a huge part of it. But I also think if folks have read the Go Big read from 2 years ago, How Minds Change, I think one thing that, one tactic that I think folks use within government relations is to ask more questions around if it is vaccine hesitancy, it's well, what concerns you? And do a lot more listening than talking. I think this was something that, when we think of advocacy, you think about using your voice, and it's certainly doing that. And I want to encourage folks to do that. But at the same time, I think it was a lot of this institution and this campus, who are very, very smart people, are here, right? They're in this room too. Talking at people about the work and about what they've found, rather than listening and hearing out what their concerns are. What have you heard about the university? What have you heard about this particular issue, right? And starting from there. I think the challenge then becomes, that's changing minds maybe one person at a time. And I think in a time when someone can, going back to your other question, Dr. Conway, in a time where people can just post one thing and cause a complete ripple effect, I think what the university, at least from a strategic standpoint, and has tried to really do is highlight those important stories that are topical, that, and write stories, and my good friends who are in content creation and strategic communications, what are the issues that people want to hear about, like how we are helping agriculture, how we are supporting, right, the workforce within the state, like what are the things people actually want to hear about that cuts through perhaps some of the noise and the back and forth. And, I think of sort of our relationship building, and our, like as a bank, and like we put a penny in that bank every single time we do a good story, or we highlight a specific partnership that the university has within a community of a policymaker. But then every time something on social media that we don't necessarily post but gets highlighted or gets distributed in like a troll type way, it sort of empties that bank with certain people. Right. And so I think social media can be such a powerful tool. And the way that we use it at the institutional level is to, identify the topics people really want to care about, and then make sure that the university remains relevant, right, by highlighting the work that we're doing in those spaces.
So then to follow up on that for Craig and Keith, so worst case scenario, I mean, I've been through multiple pandemics in my life, bad news for the young people. They happen about every 8 to 10 years. So just prepare for the next one. And that's part of why, I mean, I've been through the HIV pandemic when I was in medical school. We had the H1N1 pandemic in 2009. We've got the current bird flu pandemic. There was this COVID-y thing that you may have heard about. So these are recurring things that are going to keep happening. And so I think for the two of you, I mean, Keith sort of set the table for how the system works and sort of presented us where the breaks might happen in that system. Planning on one of those things happening, what do you see the role of the university in messaging that and helping the public understand and manage the situation?
I see the University of Wisconsin as being a place where experts from all over the world, colleagues, friends, collaborators can have a space to talk and then bring that message out, or to better understand what's happening. And so especially things like some of the diseases that we deal with, when you look at a disease in dairy cows, the milk in the cow is a USDA problem, the milk in the tank or the line is an FDA problem, right, because it's a food, and then the people are a CDC problem. So you have people from CDC that are trying to work out an issue with a zoonotic disease, but they have no idea how milk is made. And brown chocolate milk does not come from brown cows, right? Mm-hmm. I mean, but even getting to that point, thinking about just talking about things openly, and that kind of, you see lights go on. And that's what I think is so great about institutions like Wisconsin, is that in any one time I can talk to the state, and I'm a health official, or Dr. Westergaard's office, pharmacy, law, politics, and we all know each other because we're constantly in that same space. So that's what I find really it's almost soothing if I have a question and just call someone and ask. But it needs to be in front of people when we talk about this, where oftentimes no one really wants to hear about public health except for the people in this room. And they don't want to do something until the barn is on fire, right? So I'm thinking about, how do we change that narrative about things that people don't want to hear about into things that do get them to perk up. And that's why I repeat always that food security, national security, and because that's what kind of makes us unique and why we have so many opportunities in a changing world.
And so Craig, can you take it from there then? So how do we set the table and prepare the public for these kinds of conversations or these events that ultimately are going to happen at some point?
I think one of our problems as scientists, we frequently rely on data and try to communicate data, and that gets lost in the message. And I think my colleague, Mike Osterholm from the Minnesota Department of Health and the University of Minnesota, one of the things that's really special about Mike, he's a great storyteller. And telling stories that communicate data and implications of data in a way that resonates with people and how it affects their lives is really the ingredient that we need to bring into the discussion. And not everybody is set up to be a strong communicator that way, but humans are storytellers. and coming up with stories that reflect the implications of the choices that are being made is really, I think, what we need to address the public with.
Excellent. Let's open it up to some people from the audience. I don't know where our microphones are. So who wants to jump in and either ask a question, make a comment, say something provocative, share a recipe?
While we're thinking about that,
Yeah, right.
to
We
get
can
it
just
started,
keep going.
I actually have a question for you.
Oh, great.
And I heard this, right? We were having a discussion and someone said, you know, we saw the same science hesitancy after the 1918 Spanish flu epidemic. And it required FDR, and he almost lost that vote for polio vaccine, or I'm correct, hopefully I don't say something wrong. But it was really challenging throughout the Depression because people were afraid of it. And I thought, and we're doing the same thing now. So I kind of wonder what will be that event. But I mean, do you have anything else to say about that? Or what can we learn to not repeat history over and over again?
Yeah, I mean, I think that's a really great question. I mean, you know, Ryan and I and others talk about that quite a bit. I mean, I think some of the things we've learned and relearned, you know, with each of these pandemics is that scare tactics and negativity don't win the day. That, you know, really what I think as you're trying to message with people, it is listening and communication, but what they want is actionable recommendations that are generally framed in a positive manner, that they want to be able to do something that's going to be beneficial. One of the things we learned the hard way in dealing with vaccine hesitancy is studying the response of people as you gave them more information in certain ways. And so if you gave them videos of pictures of how terrible these diseases are, the heuristic sort of protective nature of the human brain kicks in, and inevitably people are paralyzed. And so the result was that when you had videos playing in waiting rooms of scary looking kids with bad diseases, people tended to just shut down and do nothing. And so really one of the key things we've discovered is you want to be able to sort of empower people that they're doing something on their own behalf, on the behalf of their family, but that also then secondarily may benefit their community. You know, part of that plays into scientific literacy. And I think one of the things that I see as a major power of this university, in particular because it is co-located land-grant university with health professions, is that outreach education that is done, the constant visits from school children, the outreach into schools across the area, but across the world. And so as we send, you know, we're one of the largest universities for exporting students doing study abroad at any given time. Similar to what the Fulbright and the Fogarty programs were designed to do, it's to share and collaborate, learn from each other, and develop those relationships of trust so that you're actually, when you're in a response situation, you've already built those relationships, but you've got positivity that you can direct people to do things that are going to be beneficial for themselves and their family. So sort of to bring it all around, I think what we've discovered over and over again is that negative and scare stuff never works. And the more that you can sort of get messaging along the same route, you know, one of the things that we all dealt with during the pandemic was disconnects between science and what government needed to do. Again, understandable in an urgent situation, you do the best you can, but one of the big failures that Tony Fauci and others acknowledged was just the simple statement of saying, we know we told you X with the best information we had this week. Now we know more. Okay, we weren't absolutely correct. This is really probably the better answer right now. I think that open communication, as everybody's discussed, includes being transparent about the process, explaining the process, but also explaining it's a work in progress. I think the other thing that we have to also be careful about is sharing things too quickly before they're actually well established. You know, one of the things we know, this we dealt with all during the pandemic, was these preprints, that suddenly something new and exciting was out there that everybody got excited about. Science is the process that is extraordinarily boring sometimes of replication, of can I do something over and over again in different ways that gets you the same result? And until you can do that, it really cannot be established as fact. The public does not understand that part of the scientific method. The public wants to know what's the latest thing that you've discovered. That's not always the best thing for them to understand. And so one of the things I think that also follows up on what people have learned over these years is I wouldn't say hold things back, but make sure it's couched in honest terms of what it actually means. And if we don't know what it means, telling people we don't know what it means. So those are my, in a career of having dealt with these things over and over again, the things that I've picked up, including being with smart people around this campus that call and ask me questions, but I call them and ask them questions on a regular basis, and having sounding boards to sort of share, hey, I'm thinking about this, or NPR called and they want to talk about X. I understand this part about it. What about this part? And people often talk me away from talking about certain things because they don't think they're going to be productive or valuable. Taylor, back in the back there. And online, please don't forget, put your comments, questions in the chat, and hopefully this magic box here will share those with us if they come through.
Hi. Oh, yeah. I think, Dr. Conway, you're already starting to answer the question that I had. But I was going to reference back to the COVID-19 pandemic and how once it started, I think it broke or it revealed a lot of the weaknesses that we have in communication between like science and the general public because precisely of those unknowns. We were dealing with a novel virus. We didn't quite understand it. And there's still some things, obviously, like scientists want to be on the safe side and be like, I personally remember going to the grocery store, coming back home, and then adding like disinfectant to everything, hosing myself down before walking into the house. But I think, obviously, not knowing the answers to everything can sometimes lead to misinformation or hesitancy. And then there's the issue of, yes, there was a boom in research. There are some preliminary studies that showed that ivermectin could have had an effect on COVID when it doesn't really do that. So I guess like before getting into the weeds of all of this, how do we deal with uncertainty as scientists and as communicators in a responsible manner to reduce some of that hesitancy?
Great question.
Yeah.
What do you guys think about that?
I would start with do no harm. That's part of our creed as veterinarians and same as our human physician counterparts. In the first place we do is do no harm. And then the active listening that we were talking about before, everyone deserves to be heard. Not everyone is entitled to be agreed with 100% of the time. So how can you mix those three and walk that balance?
Yeah, I mean, I really appreciate the question, the fact that you're acknowledging that, what happened during pandemic kind of revealed the weakness. And now you think about a weakness. What is the weakness? What is the thing that, kind of you didn't really make the whole communication like as effective as we would otherwise expect? I think going back to Dr. Conway's earlier comment is we know how to do things, right? So based on decades of experiences, professional scientists, they know how to tell their stories. They know how to provide advocacy information. They know how to deliver their messages like in a meaningful, resonating ways that can cause like meaningful changes. But I think what the weakness is, we don't really have an infrastructure at a time. We don't really have like the established channels between universities and communities at a time. All these amazing experts are trying to deliver their own messages, tell their own stories, do these different like media reports every day. But what is the infrastructure, right? So do we actually have a very reliable, established channel where like our community members, people from Madison, people from Dane County can actually go and see what experts at UW-Madison have collectively come up with. So I think, over the years, kind of going back to the earlier question as well, building that infrastructure, I think is already in the genes of this university, thinking about Wisconsin idea, thinking about, all of these extension work that we're doing at a university level, I think really institutionalizing that into an infrastructure that allows our experts to directly speak to our audiences will potentially mitigate a lot of the issues that we see associated with these emergencies. Yeah, but thanks so much for that observation.
Yeah, it's a great question. I mean, one of the things that I'm thinking about is how many times did you hear during the first phase of the pandemic, oh, we've launched an airplane and that we're building it as it, I mean, people kept saying that. And one of the things that it really occurred to me was that was unfortunate that we didn't already have an existing plan and structure for detection of outbreak, collection of scientific information, digestion and sharing of that in a way that was productive. I think there were a lot of people, unfortunately, in the scientific world that were bandstanding a little bit and sort of getting themselves, I want to be the first one to share this piece of information. I discovered this, I discovered that, without pausing and thinking like, what are the ramifications of what I'm telling people without understanding it? And if there had been a better organized network and communication system where people could sort of tap the brakes and say to each other, yeah, but what does that mean? What is this? And so I think that's the part when people were talking about, we just launched an airplane, but we're building it while it's starting to fly. That's much of what it was. And I think many of us, myself included, had a little bit more faith that the public health system was more integrated than it is. And I think one of the things many of us had to rediscover was that the United States is like 52 separate public health systems, maybe 1,000, because all politics is local, but all public health is local too. And so all of it was really, for most of our history, based on county responses and sort of regional responses. But when you get something that's sort of sweeping across the country and happening very quickly, we aren't really set up for that. And part of the discussion and the argument that we're making is that universities may be in some ways better positioned as networks in some ways than what government agencies may be set up for, just because at some level they may have a little bit more ability to be nimble, but also already have these pre-established relationships that they may be able to leverage. You still need leadership, you still need people to do that coordination, but hopefully these kind of conversations help people be a little bit more prepared, not for if the next one happens, but for when the next one happens. Any other questions or comments? We've got another one back here. We'll take a few more and then we'll move to the next segment.
Thank you all for putting on the great chat. And I was just wondering if anyone could comment on, we talked a little bit about social media, but specifically AI in emergency preparedness and how that might shape the communication that we see and like the nuance of what people are trusting online, where they're getting their information from, reputable sources, things like that.
I'll look at you.
Yeah, I mean, like when I hear that question, I'm like, oh yes, that AI question. But but first of all, what kind of AI are we talking about, right? Because AI just changes so fast. Yesterday we were talking about ChatGPT, and next day we may talk about, like a cloud or like, these like AI agent or whatever, all of these tools are just like changing very rapidly, and their implications on our overall information environment has changed very rapidly as well. So of course, like misinformation, disinformation has been amplified by these tools. Right now, you can just create whatever out of the little text that you put in there. So I think it's gonna make everything even more challenging, and the fact that people start using these tools to like seek answers regarding all sorts of questions will also be troubling. So yeah, I think it's a hard question because everything that changes so fast. I don't have like a concrete answer and be like, yeah, this is what research shows. This is like how AI influences us every day. But I think just be aware that it's not just social media, it's not just TikTok. Now you have people using these synthetic tools to search information will be very concerning. And very challenging for like emergency preparedness for sure. Yeah,
I mean, I think in the vaccine information world, I mean, one of the things I think you're getting at is that when we look at these large language models, it's where do they draw their information? And unfortunately, there's just as much misinformation as there is information. And so many people are far too overly trusting of AI and what it can do right now. We see it all the time in the medical world. It used to be people came in with their Google searches. Now they come in with whatever their favorite AI thing is. And it is a little terrifying, the stuff that sometimes comes out of that. Now, sometimes it's really very accurate. You hear these stories about people who are undiagnosed and go to multiple specialists, and by using AI, they can get at least a little better handle on their symptoms. But it's unregulated at this point and really needs that higher level understanding. Again, that's where I think there's going to be some kind of collaboration that's going to be necessary. The government's going to have to regulate this at some level, whether we like it or not, essentially as a utility. And at some level, there's going to have to be some regulation. And we've already seen the courts saying, yes, there is responsibility of the producers of these things for what the outcomes may be. So government is going to be a part of this, and then universities obviously are going to be the sort of independent arbiters of how good is this stuff and what are the ways that we actually build these in a way that are productive. So I see that as a great parallel to what pandemic planning, pandemic alertness, and then pandemic response, that may actually be the next pandemic, is maybe AI is the infectious disease that Keith fears and that she studies. I mean, we just don't know at this point, but it is a great thing to think about that I hadn't thought about much until now. I don't know if you have any comments about how government is starting to think about this.
Yeah, and I think, a little bit on how government is thinking about this, but I do want to add, I'm watching this very closely because I don't live and die by the polling like some political people do, but we've never seen sort of political perception around AI has dropped significantly in the past few months. A lot of this is because people are linking it directly to the development of data centers around the state. And I get that they're different, but at the same time, I think people who don't have a good understanding of data centers, who don't have a good understanding of the technology, are linking those two together. And I'm sort of bringing this back right to the trust issue of I think people are starting to get a little bit fearful of it because it is so unregulated. And so, from a government perspective, I think there is this acknowledgement that they have to do something, but it's sort of what is that something? At the state level, I can just say that there's been 3 different task forces on this. And then there haven't been people that have coalesced around a certain set of recommendations because there's so many considerations around how do we regulate this and should we regulate it, right? For free speech purposes, people are treating this as if all of it is fact. And frankly, it's only as good as the prompt you put in it, right? So, and what information is it drawing from? So that's one we're watching very closely. But I think to the university itself, I think folks know there's a new College of Computing and AI, there's work that is being done, in this space. And so we want to be part of that conversation, but watching it from a political lens.
We're going to wrap up. I'm going to give Craig the last word here just because you're our visitor and haven't had a chance to jump in.
I really appreciate the opportunity to be here. And I think, Wisconsin and Minnesota have tremendous history of working together, sports teams, rivalry apart. But I think, the relationships that exist across our states really are models for a lot of what we need to build trust around a lot of these other issues.
Great. Well, I think we'll leave it there. I want to thank our panelists again. If you want to join me in giving them a great round of applause.
Thank you.
So we're going to take a brief 5-minute break here to transition to our keynote address. When we return, my friend and colleague Jennifer Kushner, who's the Director of Global Industry Partnerships at CALS, is going to be kicking us off and facilitating the keynote with my friend Ryan Westergaard. So take 5, and we'll meet back here in a few minutes. Thanks, everyone. All right, we're going to get started here in a moment. Johnny, if you can take your seat. I love calling out my former students who are now faculty members. All right, welcome back, everybody, and thanks for sticking with us. We've got another really exciting and interesting portion of this same conversation that I'm happy to move towards and have the benefit and the pleasure of introducing Jennifer Kushner. As the Director of Global Industry Partnerships at the College of Agriculture and Life Sciences, Jennifer provides and supports international engagement in agriculture and life sciences at the University of Wisconsin-Madison. For the past 30 years, she's led and evaluated U.S.-based and global initiatives related to agriculture, the environment, and health, and specializes in systems approaches to complex issues with focus work on water. We're pleased to have CALS as a co-host of this event and welcome Jennifer to the podium to introduce our keynote speaker. Please join me in welcoming Jennifer. Thank you.
Good afternoon. Move this down a little bit. Thank you all for being here. It's a pleasure to co-host this year's Global Health Symposium, which highlights the value and importance of academic leadership and alliances when establishing community trust during emergencies. We're now going to continue with our keynote presentation. Please help me in welcoming Dr. Ryan Westergaard. Dr. Ryan Westergaard is a faculty member in the Division of Infectious Disease within the Department of Medicine at the UW School of Medicine and Public Health. He is a practicing clinician providing patient-centered care for people living with HIV, a clinical investigator working to improve HIV treatment and prevention, and a public health leader serving Wisconsin communities. Dr. Westergaard aims to build bridges between the scientific and educational missions of the university and the public health mission of the state, local, and tribal health departments, seeking to leverage UW resources for the benefit and health of all Wisconsin's residents. Dr. Ryan Westergaard is also a professor of medicine and the co-director of the Syndemics Research Group at the University of Wisconsin School of Medicine and Public Health, which is a multidisciplinary team whose mission is to conduct high-impact research aimed at providing health for people and communities affected by substance use disorders, infectious diseases, and related social problems. Since 2019, Dr. Westergaard has also served as the Chief Medical Officer for Communicable Diseases at the Wisconsin Department of Health Services, providing leadership for state and local public health agencies in the area of infectious disease surveillance, outbreak response, and pandemic preparedness. For the 2024-25 academic year, he was selected as a Fulbright Scholar by the U.S. Department of State and the Fulbright Foreign Scholarship Board, and applied his expertise as a technical advisor to Rwanda's Ministry of Health to expand their healthcare workforce to meet the World Health Organization's recommendation of at least four healthcare providers per 1,000 people. He also offered support for the creation of Rwanda's first infectious disease fellowship training program for physicians. While in Rwanda, he was able to also provide hands-on support during the country's Marburg virus outbreak, and we will hear a bit more about that experience tonight. Side note, I was just starting to hear a little bit about it right before this, so I'm excited to hear a little bit more. We are incredibly honored to welcome Dr. Westergaard as our keynote speaker. Thank you, Ryan, and the floor is now yours.
Thank you, Jennifer. It was a lovely introduction, and while thank all of you for being here. What a tremendous event, and I'm incredibly honored to be able to share, to participate and share some of my experiences, both with the COVID pandemic and our experience in Rwanda. Taking the lead from Craig, who said that it's stories that move people, not data, I'm going to tell two stories tonight, if I can figure out how to advance my slides. Right. Both of the stories are from outbreaks of communicable diseases and about how governments and scientific partners came together to respond. One of them on the left is SARS-CoV-2. You're intimately familiar with this because we all lived through COVID. And the one on the right is the Marburg virus. It is much less prominent, of course, than COVID was, but it's no less important when we want to think about the challenges that face us as a global community. I don't have any financial conflicts of interest to disclose. I will be discussing some investigational therapies that were used in research settings during the public health emergency. And I'll also note that any opinions that I express are my own and don't represent any official position of the Department of Health Services or the university. In many ways, global health is the ultimate team sport. Even in this room and on this stage, we see that people working across academia, across government and industries from a number of different backgrounds contribute in different ways to this mission. But what I'm going to do tonight is talk mostly about global health through one particular lens, and that is government public health. Because while we have extraordinary resources in academic settings and industry, there are certain functions that are essential to protecting global health that really only governments can carry out. That's why the third story I'll share, or that I'll begin to share because I consider it unfinished, is the story about partnerships between government and our university. It's the story about how health departments of the future, working in closer partnership with universities like ours, can rebuild trust through sustained and visible service with our communities. So let's start. First story, December 2019. This was when the first cluster of viral pneumonia was reported in Wuhan in the Hubei province of China. And it wasn't a government that first sounded the alarm. It was a crowdsourced infectious disease surveillance network called ProMed, which signaled that something unusual was happening. The WHO became involved and issued its first alert about the outbreak on January 5th. And then exactly 1 month after that, we here in Wisconsin identified the first confirmed case of COVID in a traveler returning to Dane County from China. And from then, we were off and running. To set the stage for the discussion, I think it's worth going back to highlight what we understood to be true at the time about the new virus. We knew it was a beta coronavirus. And while it was novel, it wasn't entirely unfamiliar. We had previous experience with SARS and MERS, also beta coronaviruses, and they were highly pathogenic and raised concerns about global pandemics. But they were ultimately contained through routine public health interventions and infection control practices in our healthcare settings, and they never became endemic. We also knew that there were no vaccines or antiviral therapies that had ever been successfully made for coronavirus. And we believe that transmission of coronaviruses, characterized mostly as a common cold, occurred primarily through respiratory droplets and not through airborne spread. At the same time all this was unfolding, there was a widely cited assessment of global health pandemic preparedness. And this, what you're seeing on the slide, is the Global Health Security Index, which was published in 2019 by the Johns Hopkins School of Public Health, just a few months before the pandemic began. And by a number of measures, the United States was ranked #1 in the world for overall preparedness, #1 in the ability to detect new emerging infections, and the top in the ability, or near the top, to respond and the capacity to stop emerging epidemics. So if you were to look around right before COVID, you would have said that if a pandemic emerges, this is the country that should be the best positioned to handle it. And yet that's not what happened, as we know. The United States went on to experience among the highest rates of disease and death of any high-income country. And by the time Johns Hopkins took down their data dashboard, there had been reported over 1.2 million Americans had died of COVID-19. So this forces a question that's hard to ignore. If on paper we were the most prepared country in the world, why did we struggle so profoundly to prevent this level of illness and death? I'm not going to try to answer that question completely. This is something, as I think we've started to do tonight, that we're going to have to reflect on for years, probably decades. But I am going to share a couple of examples from inside the system, my role at DHS, that I think helps illuminate a part of it. One of the earliest places where this gap became evident was in diagnostic testing. An early disappointment in the US response, and one that continues to receive a great deal of attention was the slow scale up of laboratory testing through CDC. From a technical standpoint, once a viral genome is sequenced, developing a PCR test is actually not that complicated. Many labs around the country can do this, including academic labs. But scaling testing up for a population, especially during an emergency, is not just a technical problem, it's a systems problem. And there were important decisions made early on in our government at the national level about standardization and the use of a centrally developed assay that delayed implementation. And as a result, many capable laboratories weren't able to deploy their own tests, and this led to delays. On top of that, when the CDC developed assay was distributed to states, there was quality control issues with one of the reagents, which led to delays and added to the frustration. So when something as fundamental as testing for a new disease isn't working the way that people expect, people in the community and even experts in the field, it's very difficult to build confidence in that system going forward. So in Wisconsin, how did we recover from that early gap in testing? Well, the answer was through partnerships across government, public health, academia, industry, and even a bunch of friends that I made in the National Guard. So 2 UW-Madison entities, the State Laboratory of Hygiene and the Veterinary Diagnostic Lab, rapidly scaled up their PCR testing capacity, and this became the backbone of testing for COVID, both locally and here in Dane County and across the state. And at the same time, the Evers administration partnered with Exact Sciences to expand high throughput testing using their existing infrastructure. On top of that, we established large community-based testing sites, places like the Alliant Energy Center and State Fair Park, where National Guard teams supported the logistics of specimen collection and transportation. And then finally, we in public health developed the data system so all the results would flow directly into our surveillance platform, or WEDS. And sorry, a funny anecdote about that, pardon me, I'm a little hoarse, was for a time, every one of these public testing results, which were done as under a statewide standing order, were getting funneled to my Epic inbox, because the statewide standing order was in my name. So and eventually there were, I think, 3 or 4 million tests done. So I remember I wasn't spending a ton of time in clinic, but when I showed up and I logged in and I saw all of these tests, I almost had a heart attack. And more importantly, our nurses were going to kill me, because they're the ones that also helped triage that. So it's a sign of how quickly this got wrapped up. But fortunately, we fixed that pretty quickly. So sticking with testing, a second way that our approach to testing has evolved was through kind of a national conversation or marketplace of ideas about how to best use testing resources to achieve public health goals. And if you remember, there was significant disagreement. Some people argued for widespread use of rapid antigen detection tests, which were cheap, rapid, could be used on a daily basis. Others emphasized PCR testing, which was much more sensitive, but slower and more resource intensive. And it wasn't just a theoretical debate. It was being worked out in real time through studies conducted by health departments and academic partners. And we got to participate in one of those, which I'm showing here. So this MMWR article on this slide, it was led or implemented by our team at DHS, including our EIS officer, and organized by Hannah Kirking at CDC, who, as it happens, was trained here at UW. Hannah had just been asked to lead a new COVID epi studies team at CDC, among all the things that were reorganized when the pandemic started. And one of the first things she did when she started leading this team was to call us. And because she knew that here in Wisconsin, we have a combination of public health infrastructure and academic partnerships to do these studies, which, as you can see, on campuses, and also just a willingness to go out and try stuff without, and like we said, building the planes while we fly it. So it was a good fit. What we found in this study was actually pretty important. That the rapid antigen tests, which were already in widespread use, turned out to actually not work very well for people who didn't already have symptoms. You can see on the right, a sensitivity of 40% compared to PCR. So less than half of people who were in the early stages or asymptomatic COVID would be negative. So this really informed practice, and it was the ability of us to come together as a health department and a university and CDC at all these levels, which helped us drive these types of studies. We also had a fun, well, it wasn't fun. In retrospect, it's fun to talk about, but a real world example of how these questions played out right here on campus. Our colleagues at UW Athletics implemented a very intensive, very well thought out testing strategy, daily antigen testing for student athletes. Like, Keith, I think you were involved with this or at the Diagnostic lab. So the protocol was daily screening, daily antigen tests. If they were positive, they would get isolated, and the thought was that, all right, now we can keep practicing and get ready for our competitions. And this was in many ways exactly what you would design if your goal was to detect infections and prevent transmission, but unfortunately, outbreaks still occurred. And so we studied the heck out of this, and this was one of the things that was fun. And what we came to understand was through the work at our local public health department, Madison, Dane County, with support from the Diagnostic lab and Dave O'Connor's lab on campus, we sort of pieced together how this happened. The athlete had very early infection, tested negative in the morning, didn't have symptoms, went about their day, went to practice, was in a room, exposed a lot of people, exposed their roommates. The next day they tested positive, but of course by that time they were in this, they had already transmitted virus to others. So when we studied this and reconstructed the outbreak through an epi investigation and even did genomic sequencing to confirm they were all related, it was the picture that emerged was sort of entirely consistent with what we were understanding about presynaptic or presymptomatic transmission and why this was such a challenge. The last COVID-related story that I'll tell happened much later. It's one of those "do you remember where you were" moments. I remember I was having breakfast at my parents' house the day after Thanksgiving when I saw on the phone like there's a new variant of COVID in South Africa, and they were calling it Omicron. And so by this time, we had learned a lot. We had vaccines. Vaccines were now available to everybody. We had protocols. There was ongoing debates about masking, but people who wanted to were wearing masks. But yet Omicron really changed the equation. This is one of the first events that of Omicron. Well, actually, one of the first detections of this new strain in the country was in Wisconsin, and it was we investigated this outbreak to show just how extraordinarily transmissible this was at a wedding in Milwaukee County. Someone who attended the wedding had just gotten off the plane from South Africa, came right to the wedding, and the guests at this wedding were by any reasonable extraordinarily responsible. Like most were vaccinated, many were reporting mask use, except for when they were putting the cake in their mouth, they had a mask on. So it was this kind of crowd in Milwaukee, and many had deep experience in public health, including a epi department chair at a Big Ten university who spoke publicly about this experience. And yet still, transmission occurred at this event, like a lot of secondary cases, including among people who had minimal or no contact with the index case, fully vaccinated people, and even some people who weren't in the room at the same time as the ill traveler, but hours later, implying that this new virus was lingering in the air, similar to how we think about measles. So what this illustrated very clearly was that we were dealing with a virus that had become so efficient at spreading, even in settings where people were doing all the right things. So if you look at this side by side, and this is a recap of what I started with. The shift is pretty striking. In 2020, we were working from a model where coronaviruses we thought could be contained, and where transmission was primarily through respiratory droplets, but we had no vaccines or therapies. But fast forward to where we are now, almost every one of those assumptions has changed. We understand that the virus spreads through aerosols, that sustained containment, like stopping it at a population level, is essentially impossible. The huge advance is that we do have vaccines and we have therapeutics, but they don't prevent infection. They reduce risk, but they don't stop epidemics. So in retrospect, given what we know about transmissibility, it was probably never realistic to expect that SARS-CoV-2 could be contained and stopped in the way that SARS and MERS were. But importantly, I don't believe, and I'll argue this, that doesn't mean that those initial efforts in 2020 were unimportant. In fact, I think they were incredibly valuable. I think we saved thousands of lives by delaying the spread of the virus until the point where we had effective vaccines. In many ways, our scientific understanding and our capacity improved dramatically in ways we should be really proud of, but that still doesn't fully explain the gap between what we're capable of, according to Johns Hopkins, being very prepared, and what we experienced, and then finally, how the public judged us on the outcomes of the response to the pandemic. And I think this is because the effectiveness of a public health response depends not only on what we know or what we can do, but whether people trust the system enough to engage with it in the ways that we intend. So now I will shift to my second story. This one starts in August of 2024. My family and I, as Jennifer mentioned, moved to Rwanda for a year. We did not move with any intention of participating in the response to a public health emergency, but as chance would have it, that's what was in store for us. And that experience about the Marburg outbreak that I'll tell you about now gave me a quite a different perspective on the issues of trust and preparedness and partnerships. So I'll go through that now. Rwanda is a small country in East Africa. It's bordered by the Democratic Republic of the Congo, Uganda, and Tanzania. Some of you may know primarily about it through the genocide of 1994, which was a devastating event rooted in longstanding ethnic conflict. But over the past 2 decades, Rwanda has undergone a remarkable transformation. They've made sustained, deliberate investments in health infrastructure, and Rwanda is increasingly positioning itself as a leader among low and middle income countries globally, particularly how it partners with academic institutions and industry to build the capacity. I was in Rwanda through the Fulbright Public Policy Program, which was, for me, a year-long sabbatical from UW-Madison and the Wisconsin Department of Health Services, and it allowed me to embed within the Rwanda Ministry of Health in the Department of Health Workforce Development. So my role here in the Workforce Department was to basically be of use in whatever way that was needed. I was to learn from colleagues, support their ongoing initiatives, help strengthen partnerships with academic collaborators, including some that we've had, and Dr. Shirley is here, and my colleague Dr. Siraj and many others have been there. So the idea was to catalyze some global partnerships. It was also very much a family adventure. My wife, Mary, who some of you know as the emergency medicine faculty, we planned to spend the full academic year in Rwanda with our 3 teenagers. Getting there was its own project. It took many months of planning, about 30 hours of travel. You see us leaving Madison and passing through O'Hare and then ultimately arriving. Once we got there, in early August 24, both Mary and I joined the team at King Faisal Hospital as volunteer faculty, and this was alongside my role at the Ministry of Health. King Faisal is a rapidly growing tertiary care academic hospital, and it had just become the home of a brand new medical school called Africa Health Sciences University. So we arrived at a moment of real expansion. They had some new training programs, new partnerships, and really nationally a strong emphasis on building local capacity. Mary was helping to launch the first cohort of emergency medicine residents at AHSU, the new medical school. I was working with colleagues to set up the country's first infectious disease fellowship program. We thought we had a good plan. In terms of infectious disease topics, after the first couple of months, it was very clear that I was going to be spending a lot of my time talking about malaria and antimicrobial resistance. And this figure shows the number of hospitalized cases of malaria at King Faisal Hospital in the first 9 months of this year. And what we heard about from everyone was like, what's going on with malaria? There was some concern about drug-resistant, not just drug-resistant infections, bacterial infections, but actually of drug-resistant malaria, and some interesting studies that were led by Rwandan laboratory partners here. This is a figure showing through their actually very well-constructed malaria surveillance program, looking year by year the prevalence of the percentage of isolates that had specific gene mutations. So they were really proud of their ability to respond to malaria, and they had done a great job, but things were going in the wrong direction. This was something that everybody was talking about. So I thought this was what I was going to be doing, but then the pandemic or the outbreak had other plans. So the way this story started was on a Friday afternoon. I got a WhatsApp message from the chief medical officer at King Faisal Hospital. He asking me to come by, meet him in the boardroom to talk about some challenging cases. This was not a normal type of message that, to get. When I arrived, there was a small group of physicians, pharmacists, and hospital leaders who had gathered to discuss a cluster of, actually at the time, 2 patients who didn't quite fit the usual patterns that we were seeing. The working diagnosis for these first 2 cases, who were both young men in their 20s, was severe malaria, not surprisingly, but they were worsening despite treatment. And then a 3rd patient, who was a healthcare worker, a nurse who had cared for one of them in the emergency department, also got sick and was deteriorating rapidly. So it became clear there was something much more serious going on. And this part of the story was told in heartbreaking detail in this essay by Dr. Jean-Pierre, who was the ICU physician working in the unit when these first 2 patients were transferred and then died shortly thereafter, talking about his obligation to stay and take care of these patients when the entire hospital workforce was panicking and increasing numbers of healthcare workers at the facility were getting gravely ill. So what was it caused by? We were obviously concerned for viral hemorrhagic fever. The patients had high fever, organ failure, and bleeding. They were able to take blood specimens from the 2 patients that we talked about, the ED nurse, and then another hospital employee who had died about a week before, but for whom specimens were still available. They sent all 4 of these to the Rwanda National Reference Lab. The next day, on the 25th, the PCR came back negative for most of the usual suspects, and then on the 26th, the PCR was positive for Marburg, and then the day after that, the outbreak was declared publicly. So just briefly on Marburg, if you're not familiar with it, it is a filovirus in the same family as Ebola, causes severe hemorrhagic fever with high case fatality cases. And it's called Marburg because the first outbreak was actually described in Marburg, Germany, among laboratory workers who were working with monkeys that were imported from Uganda, and an outbreak of 31 acute febrile illness cases occurred there. This is what's important from our discussion of One Health, what we know about Marburg virus ecology. Its natural reservoir is the Egyptian fruit bat, which is a reasonably common species found throughout sub-Saharan Africa. And the bats carry the virus without getting sick, and they live in very large colonies in caves and mines, which can be environments that bring them in close contact with humans. On the right, you see a map from a review article that nearly every large outbreak of Marburg virus has occurred in places where these bats are known to roost. And when it has occurred, they tend to be quite severe. The largest outbreak in Angola, about 90% of the cases died. In the DRC, it was just over 80%. So when this diagnosis was confirmed, the stakes were very clear. So to talk about the response a bit, the Ministry of Health immediately activated the National Command Post, which is a structure that brings together the government, health systems, and partners into a single coordinated response. In this framework, they had actually built during COVID and was organized around 9 technical pillars, covering everything from surveillance and laboratory systems to case management, logistics, and risk communication. And what was striking was not just the structure itself, but how quickly and cohesively it functioned. There were clear lines of communication up and down. Decisions were made and implemented quickly and in real time. So I won't go through all of the pillars, but I just wanted to highlight two areas and tell a couple of stories where I had some direct involvement, and that is on the surveillance and the clinical case management. And I showed the image on the right is a tweet that is the Minister of Health, Dr. Sabin, who was a very calming presence. I don't know if he studied in Nan's class, but had a very calm demeanor and was kind of a master class in public communication, saying that yes, this is going on, but this is not. But people carry on with your activities. We've got this. This is our strategy, and there's a lot of transparency, and their system was really built for this. The health system is highly integrated and tiered, and there's clear lines of communication that stem from the Ministry of Health or the Minister of Health all the way to the community level. So it's different in the healthcare and the hospital system compared to what we have here, which is highly fragmented. But here, for the most part, excluding some private hospitals, clinical care and public health are really part of the same system. And the foundation of the public health system is at the bottom. They have around 60,000 community health workers who provide frontline services, collect data from people in real time, and maintain direct communication between the system and nearly every household in the country. The vision is for every village to have at least 2 community health workers. And that was really the starting point for understanding how the surveillance system worked. So to talk about that briefly, this slide summarizes what the surveillance system actually looked like in practice. At the center was a single large centralized system where information from clinical care, the community screening, contact tracing, and mortality surveillance all came together. And the multiple layers of surveillance here were operating simultaneously. On the top, you see the contact tracing and case investigations. This is the bread and butter. This is what we did in COVID. Disease investigators going out, evaluating people, finding out who they were in contact with. On the upper right was the national screening and triage. So in all healthcare systems in the country, we had the case definition. If someone has these symptoms, they get tested, they get isolated. If anything is positive, it gets mobilized. And this happened in virtually 100% of health posts, from the big hospitals to the private hospitals down to the health post level. And on the bottom, even more, what was really impressive to me, the community health worker workforce went door to door in their communities. They collected the data. They screened 4.8 million people for symptoms, and then identified 24 people with suspicious symptoms, but no tests. Finally, the last piece was a mortality symptom. So everybody who died in the entire country during this outbreak was tested for Marburg. And those bottom two, I think, were really important for this visibility and trust, because these are really robust symptoms, really high penetration, and there were no additional positive tests. So a lot of confidence that the outbreak was contained to the known transmission change, and gave credibility to the minister when he said, there's not community spread of this virus. You can go about what you're doing. So to talk about the contact tracing in a little bit more detail, ultimately it led to a complete characterization of the outbreak. And this diagram summarizes what we ultimately learned. There were 66 cases ultimately in total, 15 passed away. I won't go to the details of all this figure, but you can see from the long line from contact, we were able to identify contacts in the hospital from the 2 symptomatic patients that we started talking about, to previous unrecognized hospital locations, and then all the way back to someone who worked in mine that was known to have Egyptian fruit bats. So it was a fascinating exercise in what we sometimes call shoe leather epidemiology, or we might coin a new term for motorcycle taxi epidemiology, because people were getting information, going and talking to the people, and it was applied, and it was very exciting to be a part of in real time. As I mentioned, tragically, a lot of those early clusters were among healthcare workers based on the 2 hospitals, and that really underscores how important, in addition to everything else we're talking about preparedness and response, that day-to-day infection control practices in these resource-limited settings is very important. The last thing on here, you'll notice, I think I have a pointer, but the little red dot C64, we were so confident in the contact tracing that when one patient came up that didn't have any epidemiological links to the other cases, they were pretty confident. This person seems to exist in isolation. And what they found was this was another miner working in the same mine. So that was interesting, because it showed that the animal reservoir, the zoonotic reservoir, is still there, and underscored how this is something that's issue that's not going away. The other pillar where I got to spend some time is the case management pillar, which coordinated all the clinical aspects of care, included number 1, finalizing. Actually, they already had an airplane built, to Jim's analogy. They actually had a viral hemorrhagic fever response plan, but it was developed in the abstract. It had never happened. So this group of clinicians got together and said, all right, what do we know now? What needs updating? And got this document out into the community within a month, which it was moving fast. It was slower than anyone wanted, but we were not building the plane as we fly it. They had put time and effort into creating a response plan. The group overall also oversaw the implementation of research protocols for investigational therapeutics. And these products included three things that I could do a whole talk on because the backstory and the implementation are so interesting. Remdesivir was an antiviral drug that had been used in COVID and was repurposed for viral hemorrhagic fever. A monoclonal antibody on the right, MBP091, and then a vaccine candidate. Since we're running low on time, I'll talk a little bit about the vaccine candidate. Except to show these pictures. The monoclonal antibody was a product developed by a U.S. company called MAP Biopharmaceuticals, and it was made and tested in animal models and seemed to be pretty effective when used in combination of antivirals in experimentally infected monkeys, but had never been used in human patients. They had just completed a phase 1 safety trial, and we found them on the internet and called them, and within a couple of days had worked out that they were going to ship this product to us. By the time that the goal was, by the time the plane arrived, we wanted to have the protocol under review at the ethics committee. And my colleague here, Dr. Menelis, this is pictures of him driving out onto the tarmac and then hand delivering the only 5 vials of this product, the monoclonal antibody, to the pharmacy at King Faisal Hospital, where it was reconstituted and then given to patients within 24 hours. So really, quite a dramatic story. But moving on to the vaccine, the vaccine candidate that was available was also developed in the U.S. at the Sabin Vaccine Institute in collaboration with the Vaccine Research Center at NIH. And it's a chimpanzee adenovirus vaccine, and it had already been tested in phase 1 studies and animal models. So importantly, this also wasn't starting from scratch. It had already been, there was a viable candidate that could be deployed in a research setting. In this part of the story where an organization called CEPI comes in, this is the Center for Epidemic Preparedness and Response. CEPI was created after the West African Ebola epidemic with a very specific goal to dramatically shorten the time of outbreak detection to vaccine deployment. So it was sort of Operation Warp Speed before there was Operation Warp Speed in kind of a global health mission. So they coined what they thought was feasible as the 100-day mission, which is the idea that from the emergence of a new pathogen, can we get the design, the manufacture, and begin testing a vaccine within 100 days. And as luck would have it, Rwanda was one of the first the first African country to sign this 100-day pledge. And there was a meeting in Kigali earlier in the year to get support for this. So they did much better than 100 days. They actually, from the day that the outbreak was, they actually had the experimental vaccine into person in 13 days. So I won't walk through this figure, but they published the experience. But one point working out is that the first contact between the Rwandan officials, Sabin, the vaccine manufacturer, and CEPI, this coordinating agency, happened on September 26th, which you may recall is one day before the outbreak was declared, which means while the PCR was still running on the confirmatory test, the Minister of Health was picking up the phone, calling these people and saying, we need your vaccine, let's get this in practice. And 13 days later, they had an approved protocol and they started vaccinating healthcare workers. As the outbreak wound down after a couple of months, attention moved back to the ultimate source. And this is another interesting part of this story. This is another one of my colleagues from the Ministry of Health posing in front of the actual tunnel. So what became infamously known as Tunnel 12, where the first patient had met and where they had known for years that there were a lot of bats, and actually had made some attempts to mitigate the bats in this time because they knew it posed some health risks. And then based on this site visit, another one of the also very interesting scientific discoveries was that they, with the U.S. assistance, employed an antibody test for Marburg that hadn't been really validated for use, but they went out into the community and started testing people for presence of antibodies against Marburg virus. And of the 60 or so miners who worked in this tunnel, a significant portion of them, I think 17, had previously been exposed to Marburg virus. So this is something that has actually been around for a while. It had never really been described, but it's probably likely that people can get subclinical or mild infections. And that was the story of our index case. He assumed he had malaria. He took malaria medicines over the counter. He got better. But it was actually very sadly a transmission event to his wife, who was pregnant, who then was hospitalized, became severely ill, died, and was the source of infection for a number of the healthcare workers. So, so this is a classic, zoonotic health, public health emergency, and it's a reminder that all of this ecological reservoir still exists. That this is almost certain, as Dr. Conway said, to not be our last time that we deal with this. So this is the One Health paradigm. And I think the main lesson, and we've talked about this sort of as a theme all night, is that preparedness requires us to see the connections between wildlife, between animals, between humans, and between systems, and then to build the infrastructure of preparedness that can act on them when necessary. And that sets up sort of the final idea I wanted to discuss, to put it into very quantitative, for those of us that are quantitatively inclined. This is what I think is a useful way to think about trust, which is sometimes called the trust equation. And it's typically discussed in leadership and management circles. But I think it applies very well to trust in public institutions and science and medicine more generally. And as I listen to our panel discussion and our Q&A, I'm like, yes, everything that we say, if you bear with me, can kind of be represented in this equation. So I'll talk through it. So it frames trust as something built from these identifiable components: credibility, reliability, and intimacy, all of which can be weakened on the bottom when perceived self-interest begins to dominate. So credibility reflects whether what we do is grounded in sound science and intellectual honesty. Reliability reflects whether our systems perform consistently, especially under pressure. And intimacy in this context is less about personal familiarity and more about proximity, whether people feel seen, understood, and served by the systems that claim to exist for their benefit. When these elements are aligned, trust tends to follow. And when they are absent, or when the actions are perceived as being self-serving rather than service-oriented, trust erodes, regardless of how strong underlying science may be or how capable we as an institution are. So pictured here, someone an almost embarrassingly high proportion of PowerPoint presentations I've given since my faculty appointment in Wisconsin has had a picture of this person. So you may have heard me talk about this person before, but this is Rudolf Virchow, who was a famous German pathologist who gave us things like Virchow's node, Virchow's triad. So considered by many to be the father of clinical pathology, or a founding father of pathology. What might be less known is that he was actually very highly socially and politically engaged in his time, which was mid-century Germany in the 1850s and 1860s. And he actually left medicine at the end of his career to run for public office. So Virchow said something that I think is just as relevant now as it was 150 years ago, and that's that medicine is a social science. And physicians are, in his words, natural attorneys for the poor. What he meant by that, I think, is pretty simple. If you really want to understand why people get sick, you can't stop at biology. You have to look at the conditions people are living in, their housing, their nutrition, their work, their access to care. And if you're serious about improving health, you have to be willing to act on those things, not just describe them. So the idea, which was grounded in science, careful observation, data, investigation, but it didn't end there. It needs to extend outward into society. And I think there's an important implication for that today in the things we've been talking about. Trust in medicine and public health, as several of our panelists said, isn't something that we can assume or happens automatically. It's something that gets built over time. And it's not just built by being technically correct. It's built when people can see that what we're doing is grounded in good science, yes, but also that it's consistent, that it shows up for them, and it's actually directed toward their well-being. When medicine is practiced that way, when it's clearly oriented towards service rather than itself, it earns a different kind of standing, not just expertise, but trust. So the book that you'll see on the right here is tells the social transformation of American medicine, tells the story of the Flexner Report, which was a report in the after the turn of the century that took inventory of every medical school in the country. It was commissioned by the Carnegie Foundation, I believe, and Abraham Flexner wrote a report which laid the blueprint for what we now consider modern medical education. Because at the turn of the century, medical training in the US was highly variable. Quality was hit or miss. Many were essentially private or proprietary with limited scientific grounding. And what the Flexner Report did was reset the whole system around this simple but powerful idea that medicine ought to be grounded in rigorous science, taught in close connection with universities, which many hadn't been, and practiced in settings where discovery and patient care reinforced each other. The model he felt best embodied this idea at the time was Johns Hopkins Hospital, which was founded right at the turn of the century by the four doctors shown in the famous Singer portrait in the middle. And in many ways, the transformation worked. It's given us the modern academic medical center. It made the United States a global leader in biomedical science. And as we've discussed, according to public opinion polls, when you ask the public who they trust for health information, specifically around vaccines, people will say their physician more. Sadly, they don't say their health department. I wish they did, but it's something to pay attention to, I think, that this structure for scientific basis of medical education and the ways in which we practice medicine in the same rooms that we discover new medicines is something that we need to pay attention to. At the same time, though, the same history of reliance on science, you remind us there was a cost. It wasn't always perfect. Sometimes science is emphasized so strongly that the system can drift away from the mission of service, from the patient and the community and the social context of health. So Johns Hopkins has not been routinely trusted by the community that it serves in Baltimore. That is well described. But over the past several decades, I think there's been a reckoning. Medical education has been trying to rebalance this, bring back communication, ethics, population health, and a more explicit focus on community service. And I think that's a moment that we should pay attention to when we think of the future of government public health. Because just as medicine needed to be modernized around science and scientific method a century ago, public health today needs to be modernized around something, not necessarily science. I think we're very science-based, but something related. It's the integration of science, service, and systems in ways that are visible and meaningful to the communities that were being served. So what could this look like in public health education? If the modernization of medicine came from bringing science and clinical care into close, sustained partnership or proximity, the analogous step for public health is to bring science and practice together in the same way. And that's what I mean from my title as an academic health department. This is a model where students, researchers, and practitioners are working side by side, analogous to the way that we do in our teaching hospitals, where health departments, like where I work, serve not just as sites of service delivery, but as sites of learning and discovery and evidence generation. And when we do this, the work of public health becomes more visible and more connected to the communities. Because if you go back to the trust equation, it's this kind of proximity that strengthens all three components. It grounds our work in evidence, it builds systems that perform consistently, and it brings public health in closer relationships to the people that are being served. So to get a little bit more specific, we've been thinking about this, and Jim mentioned that you said university alliances. We've used that term as well, but at DHS, we've been talking specifically about the academic health department model explicitly for the past few years, and looking to learn from places where this has done well. What I've cited here was a white paper that was commissioned, which is a fancy way of saying that our health officer, Paula Tran, just asked her population health fellows to do some research and give her a report. But they did a phenomenal job to define what is an academic health department and what that could look like in practice. And what they identified were these set of core components, things like shared infrastructure, embedded trainees, joint appointments for faculty who serve public health roles, and recognizing the numerous aligned priorities between academic and public health partners. And I think these are exactly the kinds of elements that we should be considering. In our School of Medicine and Public Health, we have a new dean. We're just starting a strategic planning process, and these components that can bring public health service in closer proximity to our university campus are things I think we should be considering explicitly as we build our strategic plan as a School of Medicine and Public Health. So this is where I'll leave you. My parting argument is that there's, in the world, if I may speak objectively, no institution that's better suited to do this work than us. You know, UW-Madison has long embraced this idea that knowledge should serve the public. We've been a leader, if not an inventor, of the concept of service learning. And as Jim also mentioned, we continue to train generations of students who go on to serve as Peace Corps volunteers, as Fulbright scholars, and in many respects in their communities at home. So this isn't a new direction for us. This is, I think as Nan said, this is part of our DNA. So the opportunity in front of us is to apply that same ethos more deliberately to public health, to government public health, and to think about how we build systems where service and science are not separate pursuits, but reinforcing one. Because ultimately it's service through science that builds trust. And trust, as we've discussed, has to be the foundation for the future of public health. Thank you again so much for being here, and thank you for all of the ways in which you support our shared mission of global health, and have a good evening.
Thank you, Ryan, for that very inspiring talk, for your very poignant stories, for your leadership in this space. I think we'd like to open it up to questions from the audience. I have a couple here that have come in through various channels, but maybe it was just first look around and see if there are questions from the group here. I think there are a couple of mics too, so if somebody's over there, just raise your hand. All right, well, I'll get us started. I have a bunch of my own, but I'm gonna take the others first. All right, so first question is, how can we implement a concept of intimacy between public health workers and the community in the US?
Of intimacy between public health workers and the US. That's the challenge, right? And one of the things that I've said was challenge is during my bio, you may have noticed I took the public health position, which was the first time I'd worked for a health department in 2019, which was right before COVID, and then I found myself as the person who was on the media briefings and answering questions. And one of the things that struck me was how as comfortable I had become answering questions for my patients, who even may have had really poorly informed ideas about their health. But when someone asks you a question that's poorly informed, you can look them in the eye, you can nod, you can show that you care about them, and it can be a two-way conversation. Public health officials can't do that. We can only talk one way. So at the more macro level, that's a huge challenge. But every community, we have 107 local health departments around the state. And similar, although we don't have the level of granularity that Rwanda does, in most of all of our counties and tribes and many of our larger cities, we have health departments with staff. And a lot of times the work that they do is visible. So how can we elevate the work that these local heroes are doing in the community? And part of that is to think critically about a trend that we've seen over the past couple decades, is that compared to when I was growing up, it was pretty routine that people would take their kids to the health department for a vaccine clinic. There are clinics that here in Madison were very well resourced, but you can go and you can get you can see the sexual health clinic, sexual and reproductive health clinic. You can get testing. So the direct services that are provided by health departments used to be much more plentiful. There's been a movement away from health departments providing services in favor of the sector. There's lots of reasons for that, but I think it's something that we can pay attention to. Is what are the ways that we can get public health workers doing visible work in the community? And I think part of that is just reckoning that when we have decisions about do health departments take on new services or back away, think about what are the implications of that.
Hi, Ryan.
Hey,
thank you for that excellent talk, by the way. One of my questions is actually the thing that you're talking about, the public trust on public health and medical professionals in general. I know you know very well. It has, in my lifetime, it has never been as low as what it is right now. And I wonder always, I'm sure you do also, and many of you, how you can recover from this and what happened also. I mean, the social media's impact is very clear. One of the things that I think always bothers me is medical professionals on social media, which looks like intentional, because as a medical professional to be going through the medical profession, trained, accredited, and a graduate, and not knowing all these basic things, I don't think is compatible. It is for that self-orientation that you said. Mm-hmm. When they are doing it, and there are a couple of them that I regularly follow, by the way, up to today, and their name is MD, PhD. Some of them actually have relocated from Canada to Florida, of all the places. How can public health, or I mean the medical profession, counteract this? When medical professionals are the ones who are pushing this kind of information, it's so difficult even for our patients in our clinic to believe it's between two accredited people, you know, between two organizations. So what solution do you have? Of course, for me, it will be an automatic firing of those people, but you know, legal system is a very slow process.
Yeah, I wish Crystal were still here to answer that question as a social media expert. I think it's an extraordinary challenge. Leaving your question about experts providing misinformation, leaving that aside for the moment, there is such asymmetry in the resources we have to put out good information compared to what's out there that it's almost an impossible task. It makes it more difficult when people who are signaled as these trusted messengers, like physicians, as I talked about, are also contributing to that. My best idea about how to address it, not to solve it, is that we are organized, right? We can speak with you know, a voice among many. We started trying to do this, you know, recently, understanding, as I said, that health departments, especially the state health department, is not seen as the trusted messenger, but we have important things that we want people to know. So we build coalitions and we make joint statements and we try to reinforce messages that come from trusted messengers. And so at our shop at DHS, we have some very hardworking communication staff, and they're thinking about ways to do that. We can't win the battle of how much on volume, right? On putting out, you know, valid information to combat the amount of misinformation. But can we do it? Can we leverage the trust that we have, harvest the trust that our collaborators have, and then in some way, and this is probably the secret sauce, organize that in a way that it's reinforcing to try to increase our, you know, our voice. You know, that's the challenge with social media, is that anyone can say anything. So what we can do, I think the strategy is to figure out how to speak with one voice and do it in a more strategic way.
I think we have time for one more question right now.
Hi, I'm Caroline. I'm one of the ophthalmology residents at UW. Thank you for an amazing conversation and talk. Something I'm really interested in is as someone who also works in clinical medicine. You know, I think, especially in our department, but across the hospital, we've seen how AI has changed the way we practice medicine, from the way we triage different clinical symptoms, questions, I'll have patients come in to the ED sometimes and say, I have flashes and floaters. I put my symptoms into ChatGPT, and ChatGPT told me to go to the emergency room because I think I have a retinal detachment. Sometimes I've found AI to be beneficial in some ways that we can emergently see the trends and maybe change some of the algorithms, especially with infection prevention and treatment, maybe a little bit earlier rather than later, but at the same time can also do harm in other ways. I was curious what your experience has been like in this changing scene with AI, if that's been helpful with preventing and controlling for these infections, or in other ways, because it hasn't been a validated tool, has it been a little bit more harmful?
Yeah, thank you for that question. I think you may not be surprised to hear that government public health is not at the vanguard of utilizing new tools that everyone else is already using. So there's barriers, there's a bureaucracy. Wearing my research hat, in the research networks, there's people using AI tools to analyze data that wasn't possible before, but also as a research tool to do things like literature reviews and synthesize evidence from a lot of places. There's obviously many tools. Again, speaking for myself, when I go to my DHS computer, I log into Gemini or ChatGPT for the things that I use it for, and it's blocked. They haven't figured out how to use this tool at a state health department. So, and they will, right? But I think it seems like we're still, when you're a large institution and a huge super agency, to adopt a new policy, I mean, there's goals to be cautious. So I think there's ways we could talk about, and this would be a great topic for next year's symposium, about how do we realize the promise of these highly powerful tools to synthesize information. Because I think there's going to be many ways in which this can support what we do and also help us understand. But I think right now we probably have the negatives without the positives. There's that imbalance there because anyone can use the tools and in a way that's analogous to social media, be led astray. We're just beginning to be able to harness the power that it can have for good. And I think that's going to be one of the things, that hopefully these kinds of discussion can inform as we figure out how to use those tools going forward. So I guess the question is I'm as curious as you are to see where it goes, but right now it's still pretty undefined.
All right, if everyone would please join me in thanking Dr. Westergaard for that incredible keynote. All right, and at this time, I would like to invite Kaylin up to the podium to kick us off for UW's Day of Giving.
Thank you, Jennifer, and thank you, Dr. Westergaard, for that incredible discussion and to our entire fireside chat for an incredible evening. Next week, Tuesday, April 14th, UW kicks off its Day of the Badger campaign, which is a 24-hour period of giving to fundraise for important initiatives like GHI and the Office of Global Health and CALS. GHI is a small but mighty team, and we are committed to improving health here in Wisconsin and around the world. As you've heard this evening, the pace and the complexity of community and global health challenges are increasing, demanding strong multidisciplinary collaboration to build awareness and trust. GHI is leading this work, and your support is essential to sustaining our momentum and increasing our impact. Every gift, regardless of size, makes a significant difference. So please consider donating by visiting dayofthebadger.org or visit our website at ghi.wisc.edu/support. Thank you. Before we wrap up, just two quick things. First, I want to take this moment to acknowledge GHI's Communication Director, Katie Newcomb, for spearheading and helping to really implement tonight. And now I'd like to invite Katie and Jennifer and Jim up to the podium to help us celebrate and acknowledge three incredible student interns who have been with GHI and the Office of Global Health for 3 and in some cases 4 years. Who are graduating this spring. So Kushi, Kendall, and Amal, if you wouldn't mind joining us up here real quick. Where's Amal? Oh. Amal. She's right here. Come on up here. Amal, Kushi, Kendall, our small but mighty teams have been strengthened by your talent, your curiosity, and dedication. The work we've accomplished over the past years would not have been as impactful without you. Thank you for everything that you've contributed. It has been a privilege to watch you grow in both skill and confidence, and we are incredibly grateful to have been part of your journeys and excited to see all that lies ahead. So thank you. All right. Should I wrap this up? Should I wrap this up, or do we want Jim to? Okay. All right. Yep. Let's do a quick photo, and then we're going to really wrap this up. You got it?
Yeah.
All right, awesome.
All right, thank you, everyone. We have some great food outside, drinks, and a lot of global health-related posters in the atrium. Encourage everybody to come out, enjoy some food, enjoy some music. Please feel free to pester the poster defenders, who hopefully are still around here. We're going to ask the speakers to stay just for a few more minutes and grab some quick photos. But thanks, everyone, for coming. Please enjoy the rest of the evening, and hopefully we'll see you next year. Stay well.